I will ask Susanna to take you through the different hygiene notices.
Okay, so good morning, everyone. So if my team wouldn't mind continuing to admit people, I'd be grateful. So just a couple of things in terms of the meeting this morning. So the first is a reminder that this meeting is live streamed via YouTube online, and there's always a link for that available on our website. So obviously that means that the meeting is being recorded as well. Also, for this meeting, we would be grateful if you would resist using the chat, because the chat isn't accessible to everyone. It's not accessible to our chair. So if you wouldn't mind perhaps refraining from using the chat for separate side discussions, we'd be really grateful. The ICP, of course, has a very long membership, so I'm not going to go through apologies in detail. I just was going to mention a couple of things, which is that there is an urgent meeting involving a number of senior colleagues from the Suffolk and North East Essex Integrated Care Board this morning, which unfortunately has drawn them away. So I'm going to be doing the update on behalf of colleagues from the ICB. Some deputies are in attendance on their behalf. We've got a couple of deputies, so apologies from Sarah Muckle, who's Director of Public Health in Essex County Council, who's represented by Danny Scholl, and apologies from Director of Public Health at Suffolk County Council, Stuart Keeble, who's represented by Anna Crisp this morning. I won't go through all of the rest of the list of attendees. Really good to see Hazel here from the Care Quality Commission, who we've been working with for some time locally, and a number of other colleagues. We do have two new members of the ICP joining: Graham Everton, who is the new Director of Adult Social Care at Suffolk County Council, and also Frankie Swords, who is the Interim Medical Director now for Suffolk and North East Essex ICB, who will be joining the ICP.
Graham and Frankie, a warm welcome to you, and to everybody on the call, actually. Do we have Councillor Fleming? She arrived yet?
I'm not sure. Can anybody see if Councillor Fleming... Yes, she is. She's on the call, John.
Jane, good morning.
I think she's ignoring you, John.
Well, she's on mute.
It's Jessica, Jane, not Jane, John.
Well, the point about Jane is because she specifically asked me not to embarrass her by mentioning that it is her birthday today. Jane, can we all wish you a very happy birthday, and you can bang me around the head at a later point, okay? So we will go on, please. Oh, and by the way, I'm not in tech support. I'll leave you to work out what I'm here, but suffice to say I'm going off to meet 52 Europeans who are flowing into Chelmsford for an important weekend, a very important weekend. So I will ask Susanna to take us through the workbook and the matters arising, please.
Okay.
And the minutes.
Okay, so we have updated the workbook since the last time we met. When we last met, Professor Pope was chairing and did ask that we updated the bring forward for the meeting, which you'll see I've done, and closed each of those items that were outstanding and have been on that list for some time. Just the other reminder in terms of the workbook is for members of the ICP, just to ensure that their declarations of interest are up to date. Those are the only issues in the workbook. Do you want me to move on to matters arising?
So can we just check it? There are no issues with the minutes? Everybody content? Any points in the workbook?
No hands.
No hands. Matters arising then, Susanna?
Okay, so the first was that we agreed that on an ongoing basis, we're going to continue to update and share our summary of high-level system risks and issues. So I'm just wondering if a colleague could put that up on the screen. We did share it in advance as part of the pack of papers. So this is just a single high-level summary. I think it's fair to say that we all know that there's an awful lot going on at the moment in terms of changes that are happening in relation to some national and regional bodies, so NHS England and DHSC and the CQC. Then NHS Integrated Care Boards, I'm going to cover that in just a moment. NHS trusts, general practice and other parts of primary care local authorities, social care providers, the voluntary sector, and of course, most importantly, at the centre, that impact around people and communities. So that is just a kind of little bit of an update. It hasn't changed very much since the last time we met, but I think it's really worth bearing in mind at the moment, just the scale of change and issues being dealt with, if you like, across the health and care system.
Absolutely. And across the system. Yep. Actually, beyond the health and care system. Okay, thank you, Susanna. And does that take us to Rachel?
It does.
Thank you. Good morning. I'm Rachel. I'm the Communities Lead in the ICP team. Just very briefly, update and following the item last meeting around the Anchors impact reports. We have shared those a bit wider now. The dashboards which Liesl produced were initially based upon work which UCL and partners have done around measuring anchors work. So we've shared that work with UCL and partners, and they're sort of sharing that more wider within their team. And also their Health Anchors Learning Network have picked it up and are interested in doing some work around that to share the learning. I think they're going to invite us along to an event in July, and they're also writing a blog. And just finally, the last impact report was specifically looking around procurement, and we did a focus around voluntary sector. And there is an interesting piece of work being led by the East of England Collaborative Procurement Hub, which are looking to develop a social impact framework, which is very much targeting for the voluntary sector and SMEs around work around health inequalities and wider determinants of health. So we're picking that up with a lot of the procurement leads, with our NHS providers, and also our VCFSE Assembly, to see how we can take that forward. Thank you.
Thank you, Rachel. Any questions? I would observe that it is a very frequent occurrence that when change happens and budgets are squeezed and the multiplicity of priorities manifest, the roles that anchors can play, however one describes them, across the wider issue of what may seem soft issues can be squeezed out. And I perceive that's happening in Essex, actually, since we lost the invaluable chairmanship of Ian Davidson from tendering. And it shouldn't, it's not an either or. Everything an anchor does in the space of inclusive employment or workplace well-being, community engagement, these are all facets which will enable the optimal of performance through sometimes more direct ways than the more obviously levers, but they will still aid optimal outcomes. And I would say to all colleagues from Anchors, please don't let it get squeezed out. All the good things that you've been done as the upheaval of change gets underway. And I do want to say to all colleagues whose employment may be at risk in the coming months, you know, our sympathies go with you, our understanding and respect go with you. Let's equally make sure that we end up with the strongest possible institutions going forward. And that's a rather sober note before I ask, but actually it's a very good intro to you, Susanna. You're going to give us a short verbal update on ICB situation.
Absolutely. So colleagues will be aware of the requirement for NHS integrated care boards to reduce their running costs by 50%. So just to be clear, this is about the cost of actually running the organisation. It's not the overall budget for the whole ICB. I was asked that question yesterday somewhere. So when that was announced in March, the timeline that was set out was that those savings would need to be achieved by the end of the calendar year. So that would be by December, obviously, 2025. So in terms of an update on that, the first part is that, of course, the need to do that is obviously of significant concern to the staff working across all of our NHS integrated care boards. And for Suffolk and North East Essex, my huge credit actually to my colleagues in our workforce team who have been putting on a very comprehensive programme of both staff briefings and also a whole broad programme of support to staff as well. In terms of the timeline, I think the best way to describe this is that we're kind of waiting for a number of kind of key jigsaw pieces to kind of come into focus in order to be able to confirm that. So one of the first issues is that reducing the running cost of ICBs as significantly as they need to means that the 6 individual ICBs that we've got in the east of England would not be viable on their own going forward. So this brings about the requirement to kind of cluster up and potentially merge in the future. And as matters stand, we expect that Region are likely to confirm very soon indeed an arrangement for clustering for the East of England, which would include a Norfolk and Suffolk cluster and a Greater Essex cluster, and that we'd need to move swiftly to start to form those going forward. Another point then is that we're still awaiting some clarity about the process and exact timeline for the substantive appointment of chairs and chief executives for those ICBs, and also for executive directors and the wider team. But we're expecting that process might begin at the beginning of July. Another area that we've been waiting for clarity about is what the arrangements are nationally in terms of the inevitable redundancy costs that will be result from the restructuring that will be necessary for ICBs. Some of you might have seen this week, well, actually everyone will have seen that we've just had the spending review this week, and one of the things that was reported on the back of that was that redundancy costs would need to be met as part of the kind of settlement. They won't be met separately by Treasury, so they need to be met locally. So at the moment, what are we doing? Well, we're rapidly working through a high-level structural design. And for Suffolk and North East Essex, that would actually mean a reduction of around about 60%. And that's because of the kind of dual impact of needing to reduce costs down for Norfolk and Suffolk in line with the £18.76 per head budget that we need to, and also because we need to adjust, if you like, the budget, if you like, available for running costs to account for North East Essex not being part of a Norfolk and Suffolk system going forward. For Essex, my colleagues in HR are working through, together with Hertfordshire and West Essex ICB, what would be a kind of safe and legal process to determine which staff, if you like, might transfer into a kind of Greater Essex pool as well. So it does look as if July is going to be kind of, quite a key time in terms of starting to move some of this forward. In terms of kind of the overall timeline, I think it'd be fair to say that, it's not rocket science work out. It's going to be very, very tight to achieve some of these changes in line with the timeline that was originally set out. But again, huge credit to everybody that's working very, very hard on this at the moment. It is quite a significant distraction. To give you some idea, for with Ed and Will now both having interim roles leading both Norfolk and Waveney and Suffolk and North East Essex ICBs, we've been holding joint briefings, and you can have a staff briefing with around 800 staff online. And lastly, I just want to mention that working very closely and very well with trade unions, who are very grateful for the kind of the style of working that's emerged locally as well. So I think that's all I've got in terms of kind of notes for that update. I'm probably not the best person to take kind of questions and so on, and it might be that for some things they remain questions that are just unanswered at the moment.
Yeah, I think if I was to just come in, thank you very much for that, Susanna. Firstly, as one moves to new integrated care boards, it's as critical that they are all new, that everybody across Norfolk and Suffolk feels well and fairly dealt with. Similarly, across the constituents which will come into Greater Essex. I can't do much in this space, Susanna. I really need to look to you, Will and Ed, and to your counterparts in West Essex to work with Mid and South Essex to ensure that there's utter transparency and fairness and objectivity in the creation, the designing, and the populating of the new integrated care board for Greater Essex. I can people from local government, I think, can only really get involved if invited to do so by the ICBs themselves. Secondly, I think we'd all recognise that to have this piece going on only to be followed by local government reorganisation some way down the line is not the best way to plan. We can recognise that two different departments of government were not really talking to each other. But the position in local government reorganisation, I don't know if anybody's here from Suffolk County Council, as far as Essex is concerned, the different constituent parts, remember, we've got 15 councils plus the Police, Fire and Crime Commissioner's Office are all looking at the preferred options. The submission has to go in on the 26th of September. I wouldn't be too surprised if there are two separate business cases put forward within that submission. I always go back to the letter of the 5th of February, which is in the public domain. It sets out a range of about 13 criteria, and I measure all the options against those criteria. And others prefer, for whatever good reason, to focus on one or two particularly. If you focus on cost particularly, you will end up saying, well, you should only have one or two. If you focus on local resident engagement, you will want to go to the maximum number, which is probably 5. So it's a question for me. I'd rather look at it across all the criteria. I respect those who want to look at it through particular lenses. Is Stephen or anybody else from Suffolk County Council, what's the latest with you?
Will Pope's got his hand up.
Right, Will, sorry. But right, just I think there was just one, there's nothing else I want to say. No, right. So Will, I'll hand back to you and anybody else that wants to ask any of us a question on this. Will?
Yeah, thank you, John, and Susanna, both of you. Thank you for your update, and particularly that LGR update, John. Actually, if there is somebody from Suffolk here, I'm very happy to hold on my comments while somebody from Suffolk gives an LGR update. I'm not sure we do have those. Susanna, can you see anybody there?
So Anna has just put her hand up.
Right.
I'm not deeply involved. Good morning, everybody. Anna Crisp, Suffolk County Council, Public Health. But I can say that we're in, I think, a fairly similar position. We don't know yet how many bids there will be. It is possible there will certainly be a one Suffolk approach, but I think there will also be at least 2 and possibly 3 as well going forward in September. But that is still all being worked through. So I think that's the best update I could give at the moment. I hope that's helpful. Thank you, colleagues.
Thank you, Anna.
Yeah, so, should I come back in, John, then with my...
Just so Kathy's got a hand up, Kathy Nixon.
And I was just going to say, would echo that from the Suffolk District's point of view. Yes, I would expect that there would be at least 2 proposals, as Anna says, from Suffolk. And obviously we're in, both the county and ourselves are in a period of engagement with various stakeholders and public and others.
Thank you very much, Will.
Yeah, thank you, John, and thank you, Kathy and Anna. Most appreciated. I think really very briefly on picking up John's point about a new Greater Essex footprint and then a Norfolk and Suffolk ICB footprint. It's simply to report, a bit like the updates we've had so far, this is definitely a work in progress, and there are transition committees now established for both patches. So this is a very live issue. And I think the most important thing that we all buy into as well, I know, is that we go through a fair and equitable process for all involved, and also that we get the best outcomes both for that we possibly can for the public we serve and the employees in our organisations. And I think everybody's like-minded, so it's definitely work in progress. That was my only update on that. Susanna, thank you for your update generally, which was absolutely spot on. I'm also happy if you want to give a very brief update on the ICB board meeting on the 20th of May. We usually receive that here, don't we?
We keep it tight, Will, please.
Yeah, very quickly.
So apart from this issue, what was covered?
Yeah, absolutely. I won't go through everything. It's the usual heavy agenda, as you can imagine, with lots of mechanical stuff. But we had a very interesting presentation, a verbal update from level 2 in Felixstowe, which was really inspiring. And then also a superb contribution as well, presentation on the Heart of Greenstead project, which again was terrifically inspiring from both officers and indeed local councillors, politicians, which was great. I mean, the work that's been done on both of those projects, I think, is a real credit to those involved and adding value locally to the population. So we were really pleased to receive those. We had assurance on the findings of the CQC Section 48 report, with a further report to come in September. Assurance on the Physician Associates report from Andrew Kelso. Susanna gave a great Anchors Programme Board update, which we've received at ICP before, and those reports were also then endorsed by the ICB, having been endorsed and approved here. And then just 2 more things, I think, which I'll flag. I'm not going to. We discussed the sustainability review, but I know that's on the agenda for today, so I'll leave that. We had a great equality, diversity and inclusion update from Manda, which was really helpful. And we also received the staff survey results for the ICB, in which I think it's fair to say, I know it's fair to say, we had the best staff survey results of any ICB in the country, with every criterion being either first or second in the country, which is a terrific staff survey report, and actually to the credit of the executive management of the ICB, but also to the people who work in it, the people who are part of that team and who contributed and made that happen. Whether we'd get the same today in the light of the reorganisation is another question. I think those are the highlights, John, and I'll leave it there.
Thank you, Will. We lost you for a second. I think we got the thrust. That's very thorough. Thank you. Now, are there any... I'll take questions, but please, questions, not speeches, very quickly. Are there any hands up on any of the things we've just covered?
No hands.
Kathy, you've just provoked a very interesting debate with Susanna and I. Your accent is lovely. Where's it from?
Oh, born in Northern Ireland, but had a spell in Yorkshire as well.
No, I could hear the Irish, you say. Yeah, Susanna put you somewhere in the middle of Scotland, so that's one to me. It's not that Susanna's competitive, you understand, it's just she wants to be top in everything. Right, thank you all very much, everybody. Delighted to welcome Beverly Egan, who's the chair of the Essex Caring Communities Commission. There's a couple of items today which are either flagged as Essex this or Suffolk that. Can we just forget the Essex this or the Suffolk that? Because the issues in both of them, this one and the care paper elsewhere, the issues are regardless of boundaries. The themes are the themes that we are all dealing with. So let's put that to one side and welcome you, Beverly. And as I've said to you, you've got a sort of superb paper. What we now need to do is get to a superb action plan. It's lovely to see you. And did you have a nice cruise?
Yes, I certainly did. Thank you very much, John.
By the way.
Okay, thank you. So for those of you that haven't met me yet, I'm Councillor Beverly Egan, and as John said, I'm the chair of the Essex Caring Communities Commission. Following the recent publication of our first report, I'm here to discuss our findings with you and to discuss how your work aligns with the Commission's and how we can work more collectively to deliver transformational change through the proposed commitments and actions set out in the report. Previous attempts to consider similar issues have not translated into practice. In 2013, the Who Will Care Commission set out a strong vision and recommendations, but sadly this wasn't fully implemented. The Caring Communities Commission aims to change this by being action-based and delivery-focused. We are keen to work with partners and practitioners like yourselves to achieve a culture shift and better outcomes as a result. Furthermore, Essex faces growing inequalities, exacerbated by COVID and the cost of living crisis. These are placing greater strains, as we know, on local public services. Our challenge is to reduce demand pressures. This requires us all to think differently about what services we commission, how they are delivered and by whom, and how we involve individuals and communities in finding and implementing the best solutions. We need to harness new technologies, new ways of working across the system, and the energy of local communities to meet the challenge. The 2-year commission was funded by Essex County Council. Commissioners include cross-party county councillors, Essex system leaders, and experts from academia and the third sector. The Commission's work reflects the voices of residents, partners, frontline staff, and national experts. It aims to deliver transformative action, not just thoughtful recommendations. We want to ensure this Commission is more than just a talking shop. It seeks to empower and enable communities to take action to improve outcomes for residents. The Commission's findings were built on primary research, updating the Essex Community Needs Index, surveys, etc., and consultative events, including our World Cafe Style engagement events, as well as secondary research through literature reviews from academia, think tanks, and practitioner organisations. And I want to take this opportunity to thank all of you that contributed to our commission. Our actions derive from our collective understanding of the challenges faced. A set of actions in themselves will not achieve the significant change we are seeking. The how is vital in achieving buy-in, collaboration, and taking the commitments and actions forward. We want residents to have an active voice, and we should seek to better understand lived experience so that decisions are taken and policies written to reflect the reality of our residents' needs. Co-production is vital for success as we seek a more sustainable balance between state, community, and individual responsibility. We need solutions to be those of the people, by the people, and for the people, just like Gettysburg. We need to eliminate bureaucracy that acts as a barrier to residents engaging in decision-making. We want strategic and place-based planning to enable effective collective action, where the bigger picture is resources. We should move towards cross-agency resourcing focused on the most urgent matters through genuine collaboration to maximise impact on key issues. We want to release community assets to make them more accessible so that communities can play a greater role in delivering better health and care outcomes. We need to adopt new routes to commissioning with purpose-focused organisations taking a collaborative approach to delivering outcomes. Our vision is for all communities to be healthy, active, empowered and inclusive, underpinned by strong levels of economic, social, physical and natural capital as community assets to help communities to find the best solution. The Commission proposed 5 commitments for local leaders and public services to embrace to create radical change focused around our places, work, our society, community influence and prevention. Under these commitments, the Commission has proposed 23 tangible actions, each being parts of the puzzle that will deliver better outcomes for local residents and communities whilst reducing costs for local public services. The Commission is looking to the whole system to drive the actions forward, co-creating how they are implemented in practice and inspiring further positive change. As you'll see from the slide, our actions fall out of our 5 commitments. Our place, removing barriers to create thriving communities There are actions relating to transport, specialist housing, and combating social isolation. Work, ensuring that residents are supported to access employment and training, for example, apprenticeships. Our society, revitalising community capacity by filling the £2 billion funding gap in the voluntary and community sector. Continuous professional development for VCS managers, making community assets more accessible and encouraging volunteers at scale. Community influence, enabling communities to play an active role in decisions that affect them, sharing knowledge across public services of the success of community, user-led approaches to shaping services. Prevention, moving away from transactional health and care to focus on prevention rather than cure. In the short term, this will include multi-agency triaging hubs and the Health at Home programme. But we propose that an Office for Prevention could be a key pillar of our future mayoral authority. So, our call to action is set out on this slide. Implementation, systems leadership, disrupting behaviours and taking advantage of devolution are critical to success. I am keen to encourage you all to take an active role in the design and delivery of caring communities in Essex. This is our call to action, and I'm keen to seek your views on how you and your networks can support. So, thank you, John.
Thank you, Beverly, and very powerfully put, thank you. And thanks to all of you who did serve on the Commission. And I'll say again, I don't care where the caring communities are created. If this enables the sparking of a dialogue across Suffolk, Norfolk, or any other part of the world, and it takes things forward, that's great. It's very interesting what Beverly said about who will care back in 2013, before I was a county councillor. I was deputy chair of that commission, the chairman being Sir Tom Hughes-Hallett. And why didn't it get picked up? Because the leadership of the Essex County Council changed, and the new leader said, not mine. And I understood that he had other priorities. I just share with every one of you, if this piece of documentation is not just to become another piece of paper that dies on the shelf, it will be up to every one of us in the new entities of which we are going to be leaders to take it into that new orbit, as well as to make sure it lives within the organisations which will be retained. It's not somebody else's job, it is our job. What Beverly's talking about, and if you didn't know, she said a career in care sector. She's very young, of course, Beverly. I don't mean to sound that you're old, but you have got decades of experience. I think I would just say, let's think this is going to get better. I look at the demographic changes going on around us, and the very clear, sadly, concentrations that certain people coming into the county, maybe of different ethnicities or whatever, are coming into one part and into other parts where more wealth is going. And I can certainly see that going in my home city. The inequalities will increase, and the strains on all the system will increase. So the prize to be won will increase.
Judy Newman's got a hand up.
Right, so I've finished. You'll be pleased to know. Right, so we'll take questions, comments. We can't solve this today, but we can certainly try to have a debate. And what's very important for Beverly is to hear your key concerns, opportunities, or whatever. So whose hands are up, Susanna?
Judy Newman.
So I'll start with Judy, but if we could get a few hands up, then we can just very quickly be moving from one to another. Judy?
Thank you very much, and thank you, Beverly. I'm Judy Newman. I'm the Chief Executive of St Elizabeth Hospice, but I actually sit here on behalf of all of the hospices for SNE. And so I know that if my colleagues from St Helena would be here, they'd be really celebrating the synergy with the fact that Colchester has just been made a compassionate city. And I would just say, as one word of encouragement for this, if we look at this with an asset-based community development approach, then certainly with the Compassionate Communities Fund, we found very fertile ground in North East Essex and Colchester, and the response to that Compassionate City accreditation has been amazing. So I think there's lots of strengths there that this can be built on. So that was a word of encouragement, really. So thank you.
Thank you very much, Judy. I mean, it was great to hear Will talk about the heart of Grinstead, and Pam Donnelly, the Chief Exec of Colchester, is one of our commissioners. So, yeah, we've had some really great input and encouragement. So thank you, Judy. Sorry, John.
Pam Donnelly from Colchester was involved now. Do we have other hands, Susanna?
None yet. No.
Kirsten, I think you've been having consideration of this, haven't you, Kirsten?
Yes, at Chairs Group we spoke about this, and I'm very interested in the voluntary sector section, obviously. In particular, putting some resource into bringing in the lost 2 billion of funding. It would be really good to work across the counties to see how that will work and what we can do about it.
And will probably be most likely to be achieved if you do it on a cross-county basis, Kirsten. Here's the issue. We shouldn't let boundaries get in the way. The more you can have a united voice in it, the stronger that voice will be. Anybody else?
Just to say that what we've done, Kirsten, is we've added this to bring forward for the Voluntary Sector Assembly. So, Beverly, if you wouldn't mind, we might be dragging you out yet again. And just the other thing worth mentioning is that it was really good timing that whilst you were working through this work, we were developing Future Shift. And thank you so much, because, you know, those two things, you know, there's a big overlap. So we absolutely have referenced the Essex Care and Communities work in Future Shift. And equally, if you like, I think, you know, the two things are kind of very synergistic. So, yeah, really happy with the link there.
Are there any other points, comments, questions?
Zephan, Trent.
Sorry?
Zephan.
Thanks very much, Chair. I just want I'm here obviously as a representative for Essex Partnership University FT. I just want to say how much we welcome this work. I mean, you know, from our perspective as a mental health and community provider, the work of the Care and Communities Commission is of paramount importance. And I think, you know, we've spoken earlier in this meeting about the significant changes to the organisation of ICBs and so on. I think something that, you know, the chairman and others have referred to is that the focus on place and community remains steadfast in all of that. And from a provider perspective, we're absolutely in the same place. So really welcome this. And I'll look forward to sharing this report with my colleagues at EPUT as well.
Thank you very much indeed. Anybody else?
Can't see it. Any more?
Thank you. I can't go on dragging comments out, Beverly. All's quiet. I hope it isn't all quiet, because this started with the word Essex. But Beverly, thanks for all that you're doing. I would invite anybody who at a later date thinks they've got comments that they wanted to share but weren't ready to do it now. Beverly's contact details are very visible on the Essex County Council website and the Caring Communities Commission. So do please come back to Beverly with any feedback or thoughts. Is that okay, Beverly?
Yes, that's absolutely okay. And we've got more work to do, and determined that we will continue to do that. And again, just to thank everyone that has contributed, but also encouraged. And of course, the more we can get the report into the system, the better it will be. And in fact, we're going national. We've had a lot of interest from other counties. So, you know, hoping that, as John said, it's not to do with borders. But thank you very much for your letting me come along today, and hope to see you all again soon. Thank you. Bye-bye.
Thank you, Beverly. Thanks very much for all you're doing. So we come on now to our next item around sustainability. And I think, given the ICB pressure issues, I think, Alex, you're introducing this item.
I am. Good morning, all. I'm Alex Ryan. I'm the Director of Strategy and Healthcare Intelligence at SNE ICB and covering for Richard Watson today. So we're giving an update on the latest status of the sustainability review and asking the committee to note the progress and support the kind of where we are with next steps. If there's any colleagues from West Suffolk on NESNEFT on the call, they may wish to compliment what I'm saying, as this was a joint review, but I know some are running a bit late. So I'll just segue into it then, Chair, if that's okay. So I'll update on the kind of key themes that's emerging for the report. I'm not going to cover in any detail the next steps because that's still being worked through at the moment, and trusts and ICB board are still yet to review and approve that. But the context, as you'll know, because I know Richard has covered this previously, is that SNE ICB jointly with ESNEFT and West Suffolk, we initiated this review, which is aiming to determine how these NHS organisations can work across the system to just secure high quality and clinically and financially sustainable care for our community going further into the future. The work was conducted by McKinsey as an independent organisation, but it had really broad input from colleagues across the ICS, representing a range of organisations and sectors. So thank you to anyone who's on the call that did contribute to that work. The national backdrop is key here. So the national backdrop in the context is that across acute sectors nationwide, we've got a combination of rising demand along with financial, productivity, workforce challenges. And that is placing a strain on services. And we can see that manifesting, of course, as a sort of deterioration in performance relative to kind of national standards, such as longer waiting times relative to pre-pandemic levels. So this review is also about trying to understand how those challenges are playing out locally, and are there any things that we can be doing collectively to try and mitigate some of those challenges. So it's kind of three phases to it. A really, really detailed, in-depth set of analysis to establish that kind of really robust fact base, a set of recommendations around 10 initiatives that would be prioritised to increase sustainability of healthcare delivery. And then thirdly, what are the kind of enablers, particularly around partnership, that would best support that kind of change. So in terms of the headline findings, the report looks at health outcomes, and SNE achieves good overall health outcomes. Metrics like life expectancy and avoidable mortality, they are broadly in line with what we see nationally and following national trends. But there is, of course, some significant variation in that. And we do know, of course, that avoidable mortality is much higher in areas of high deprivation. And the report does draw kind of look into that, and some of the initiatives are in reference to that. We also know that the percentage of our population that is using unplanned bed days in the acute sector is very heavily concentrated. And we know that around about 1% of the population, about 10,000 people at any moment in time, is using around about 60 to 70% of non-elective bed days. And again, some of the initiatives are around what can we do to better support that population who are in hospital because they have very acute needs, but is there a way that we can better coordinate that care? In terms of quality of care, there were clinical audits undertaken, and the findings are that quality of care is good and is consistent with national average, if not better in many cases. But of course, that is again set in the context around very challenging performance, particularly in respect of average waiting times. There's a very strong theme through the report around finances, and that's largely set in a productivity context. So productivity across the acute sector nationwide has not yet recovered to pre-pandemic levels, and SNE is no different in that sense, though the actual starting point for our productivity is in some cases very good. And we do benchmark well nationally in respect of acute productivity. But the productivity challenge, along with rising demand into the acute sector, which has outstripped population growth by some margin, does mean that there is quite significant an operational and financial strain within the sector. And again, the report goes into that in great levels of detail. It draws out a challenge of around about 2% productivity increase that's needed to, broadly speaking, just maintain existing levels of kind of financial performance. And indeed, NHS England have set a productivity challenge of 2% for the forthcoming year, and underpins the spending review. So the sum effect of all of this essentially is that there is risk that the proportion of SNE resources going into the acute sector would grow, not decrease, if we are unwilling to accept increases in unmet need and decreases in performance relative to national standards. But that's where the recommendations around the kind of 10 key initiatives come in. So there's those initiatives fall into two buckets. One is around those initiatives that are aiming at reducing the growing demand for hospital services by about 2% per annum and trying to mitigate the need for expansion of the acute bed base. And that includes some proposed initiatives around a care management service for patients that are most utilising non-elective bed days, integrated models for targeted long-term condition, which is around scaling across the whole population, across the whole system, population health management approaches, further targeted investment in health inequalities, and in particular trying to address those areas where we've got a lack of capacity, particularly within general practice in areas of high deprivation. And again, looking at how we're commissioning discharge pathways and making sure that we are maximising the opportunities there. And then there's a second set, which is quite acute sector focused around productivity. So looking again at clinical operations and workforce productivity across the sector as a whole. And again, looking at the opportunities across both providers to potentially do some functions once. There's also quite a significant part in the report around the enablers, and the key theme in there is around partnership working. And the report draws on some areas where we could be looking at collaborative working, particularly around a joint productivity board. So the next steps, the report is to be reviewed again by the ICB board, I believe scheduled for July, as well as the West Suffolk and ESNEF boards, who will then need to review the proposed initiatives and consider next steps. And there are also staff briefings going on within providers as well, which is providing a little bit more detail. So that's all I was going to update on, Chair, and happy to take any questions. I'm not sure if there's anyone from ESNEF or West Suffolk on the call.
Thank you, Alex, and it was very interesting, thank you. And you'll be delighted to know that there was unanimity in this room as to your Scottishness. There's more of a debate about which part. I'm not going to get involved in that. I'm pretty sure you're not Glasgow. Anyway, I just wonder, Alex, if I may ask from the chair, how closely did your work audit the degree to which systems remain barriers? We seem to have all this ongoing trouble still with parts of the system talking to each other. I can tell you that as far as I understand that the merged hospitals of Mid and South Essex still cannot easily share all their records about people. Even though they've been allegedly merging since about 2017. And I also encounter it in terms of relations with primary care. How with cross mergers into things to do with social prescribing, community agents, or all these other bodies, how well do you think we're overcoming the barriers that get in the way of that?
So I wouldn't say the report went into that level of detail. I think the initiatives are much higher level, and it kind of gives the scope for providers to respond to that in respect of what are the kind of key barriers that we need to overcome to implement those things. But I think system connectivity, partnership working, data sharing, intelligence is kind of like a key theme through the whole report that kind of underpins a lot of the initiatives. Those kind of left shift initiatives, a lot of them are around investment in community, permacare, and the partnership working around that, looking at population health management and targeted long-term condition support. All of that, I think, is that kind of question around system connectivity is obviously key to kind of implementing all of that.
Thank you very much. I've got one other question, but I must let other people come in first. What hands are up, Susanna?
So you have Peter Smythe, Sharon Alexander, and Zephan Trent.
What a lineup. Peter, then who was second?
Sharon, and then Zephan.
Peter, Sharon, Zephan. Okay.
Alex, a couple of questions. One is around your report or your summary of the report. It talks in quite some detail about productivity and the drop thereof. My question is, does the report, or do you have any reflections on how as a system we improve that? Because just moving care into the community per se may not get us there. If we replicate the actions that we have done, but just in a slightly different setting, I'm not sure we get the productivity gain per se. And so I think that leads us to a place of change. Do you have any reflections on that and how that might be done? And the second bit is around the previous work that the system has done on demand and capacity modelling. It seems to me logical to run those loops with the interventions that we might describe downstream of this report, so that we can actually look our troops in the eye and say that we have a plan, because this is still, it's not granular enough for us to give hope to those who are on the front line.
If you wouldn't mind, Alex, I'm going to go to the other two first and give you a collection, just in case there may be similar themes. Sharon? Sharon.
Apologies, John. I clicked on the hand icon by accident.
It's all right. I fully understand. It's lovely to hear your voice anyway. Zephyr?
Mine was really in response to your question, John. I was actually on a panel at Confed earlier this week talking about the same issue. So I might repeat some of what I said there. I think this remains a challenge for us across providers and across systems about the having the ability to fully integrate and interoperate records. And really the answer is about national standards that compel providers of electronic patient record systems to operate in a way that means that by default they integrate. And I said that publicly there, and I say it again here because I think it's critical. In EPUT, we are implementing a new patient record with Mid and South Essex FT, where I hold a joint role, which will address the point that you talked about with different systems across the hospitals there. But we will still have challenges of interface with different areas, and I think those standards are going to be critical to that. The two things which are the light at the tunnel, the end of the tunnel at the moment, and Alex, I know that you're heavily involved with these things locally, I think are the shared care records that we've got within systems to facilitate clinicians getting access to different records more easily than they can at the moment over time. And I think, the opportunities in the federated data platform and data sharing with the right controls and governance around that, so that our patients and our public's information is secure. So I think this is an area we've got to keep working on and keep working hard on it.
Definitely, I'm grateful for that, because I believe, Alex, it's maybe a bigger issue than one appreciates. I know there is much concern within your ICB that progress on this could be lost by the reorganisation. And we should always remember how many of our residents are crossing systems in order to have care. They are not led by ICB. So there are many. Now, I live in Chelmsford. The theoretical referral point for cancer tends to be Southend, but actually most residents are sent to Broomfield or to Colchester. And the wonderful orthopaedic unit at Colchester is also now importing many patients from other systems. Alex, do you want to come back on any other points? That or any other points?
I'll come back on Peter's questions, if that's okay. So they were really good questions. So the productivity, how are we going to achieve that productivity? So there's, like I said, there's two parts to it. So the report acknowledges that the productivity challenge is significant, and even a 2% per annum productivity increase is more than double what historically has been achieved in the acute NHS sector pre-pandemic. And in reality, we may need to go in further than that. And that can't just be achieved within the acute organisations themselves. And an element of left shift will need to contribute to that. But to your point, there is not an expectation, I think, through this report that would completely fulfil that. And therefore, there are quite a lot of there's a reasonable amount of detail around where the areas of focus should be in respect of productivity, but both providers do have productivity programs set up, and they would be able to talk to that in much greater levels of detail. And the report has a recommendation around a joint productivity program or program board to oversee that work, given the level of importance that is going to have in respect of those future kind of financial trajectories. And yeah, your bit around demand capacity and closing the loop, I mean, that makes perfect sense. I mean, the report kind of sets the trajectory and what contribution kind of productivity improvements can make to that. But once we actually are clear on what those programs of work looks like, we should be closing that loop, and that's what that program board should be trying to achieve, I think.
Well, Alex, thank you very much. That's good. Yes, very interesting. And I've got Laura's hand up. Anybody else's?
Just Laura.
I'm just going to pause for a second, Laura. Anybody else?
No, there's
You're very, very passive this morning, you all are. Right, Laura, over to you.
Yeah, thank you. Just really quickly, just coming off the back of what Stefan said, I think sometimes as well it's really important that we recognise that the systems can do the integration, but we don't put the time and support into the behaviour change and the staff support to change to use it when we do that. So I think just wanted to add in that point really that there's a lot of system change coming for everyone, and change is scary, particularly when you're in a busy health setting and adding a new system or a new way to do it. So making sure that we keep that part of it engaged in that as well.
Absolutely, Laura. Thank you. Is there any else?
No more at the moment. No.
Alex, thank you very much. And again, if you have any later reflections on this paper, you're very welcome to go back to Alex. It was very interesting. Thank you, Alex. Which brings us to integrated neighbourhood teams, I think. And once again, this is a progress report and developments in Suffolk. I would say it's a progress report and developments. And who's taking this one again?
So we have a team from Suffolk County Council, Clement and Vimy and Louise as well.
So Clement, Billy, Louise, over to you, in whichever order you're doing it.
Okay, thank you very much. And we really welcome the opportunity to be invited in order to give an update on our integrated neighbourhood teams. So just as the chairs mentioned, the progress around our integrated neighbourhood teams, though this is focused on Suffolk, we have worked very closely with colleagues from the Norfolk and Waveney system, as well as colleagues from Essex. Vimy, if you don't mind sharing the slides, if that's okay. So I'll just start off with a bit of background and I'll hand over to my colleagues. So we've been on a really progressive journey across our 16 integrated neighbourhood teams in Suffolk. Our teams are really centred around place and are focused on providing positive outcomes for our population. Our integrated neighbourhood teams are made up of adult social care as well as community health colleagues. We have worked and developed a one-team approach which really places the population we serve at the centre and doing what is the best for our population. In order to provide our integrated neighbourhood teams provide a really good foundation to enable us to actually adopt the future shift. In particular, looking at moving from hospital to community-based care. And we know that in order to achieve this, we really need to work well and we need to work well with partners in order to achieve the great outcomes for our population. In saying this, we've made really positive progress with working with primary care networks across all of Suffolk. We've made really positive strides working with the care market, as well as working with the voluntary and community sector partnership. We're mindful that each alliance is focused on looking at preventative or proactive models of delivering care. In saying that, there are really positive opportunities that we have picked up and are looking to adopt around interoperability, which is the point which was raised during Alex's sustainability update. We are working with Joe Lennox as well as IT leads from Essex and the Foundation Trust, Essex Suffolk and the Foundation Trust, to look at how we can enhance what is currently provided through health information exchange. And my colleague Vimy will touch on a bit more of that during the presentation. I just wanted to reflect that the slide here really shows the scale of work that is happening and the level of partnerships that are across the health and care system in order to continue to support positive outcomes for our population. We recognize we have a lot more work to undertake, but we're starting from a really positive place, which will enable continued positive outcomes for our population. I'll hand over to Vimy to talk through the next slides.
Hi, everybody.
Thank you.
Sorry, no. I was don't mind. You carry on. I was just going to ask Clement a question. I'll wait till after. Thanks.
No, it's okay. I'll pause.
Oh, that's awfully nice. It was just Clement. So because my responsibilities spread across children's services and adult social care and public health stroke NHS, I hear my children's services function being concerned that the ICBs don't pay enough attention to children. And I hear others being concerned that children's services aren't engaged enough. So you specifically said that the Integrated Neighbourhood Team is adult social care, not children. I'm just wondering, when so many of the issues of healthy living start from the womb, when so many of the things are set, whether it's to do with oral health, healthy weight, avoidance of getting into bad habits of eating, development of physical exercise, our childhood, why would you specifically pick out adult social care rather than, and I'm not having a go at you, by the way, I'm just asking the question, why would one not want to have children's services in the INT?
I do think there is a really great opportunity for us to expand the integrated neighbourhood team or neighbourhood team working approach to children and young people services. We are aware that central government is advocating or is giving an indication to expanding neighbourhood working to children and young people services. There certainly is an opportunity for us to enhance what we're doing in partnership with children and young people colleagues. But that is a piece of work that I am aware across the Suffolk alliances we are currently discussing and exploring through the alliance delivery Live Well delivery framework. There is one of the domains is really focused on which is the Start Well domain, which is focused on working with children and young people. I think it provides us with an opportunity to really focus on how we can expand the work within neighbourhood teams, building on the good work that does happen across children and young people services currently.
I hear that. I hear government, I hear exploring. I'd really encourage you in any correspondence you have into Essex. I don't know what more we have to discuss. It is self-evident, I would suggest, and I continue to press from my end. Just as there are no boundaries between Essex and Suffolk, so there's no sudden boundary between children, young people, and adulthood. And so much of what goes on, so if, for instance, in our inclusive employment programme, that is all focused at the moment on when a young person's leaving school, becoming a care leaver, whatever. The die is set, particularly if they've got disabilities, with the whole attitudes of them and their parents and their carers from a very young age. And if they haven't been developed in ways that encourage their confidence, and I speak as a blind person who has worked with all the disability charities in the country, if they aren't fostered in a world which doesn't just wrap them in cotton wool from the earliest days, then they're not ready.
You've got a hand up.
You've got to make them world ready. So I would really encourage and provoke Clement action in Essex, and maybe come to the conclusion we've debated enough. But that's me off my rant. Peter.
Thanks. So if I can contribute sort of my perspective on this from West Suffolk Alliance and sort of the experience in working in integration for many years, I think the philosophy and the service direction you describe is John, is absolutely spot on. So I think all of us have that direction in our mind that we need to have integrated neighbourhood teams that are working for children and families in the same way that we are having this programme around adult services. I think there's something about a practical point here of who the people are we're connecting. So the professionals ultimately that we're connecting in adults' world, what a better phrase, it's the adult social workers, because that's how we organise our team. It's the adult mental health workers and some of the discharge teams. The client group that they're working with are what they have in common. And so what this project is trying to do is to remove the barriers between those professionals working in that space. And I think we do to an extent, but we do a lot more to the same with children and young people. But of course, when you're in the children and young people space, you're then talking about education, you're talking about schools, talking about midwives, health visitors. It's a different professional group. And I think it's right to call out that we are not as advanced and as clear in our implementation for children and young people as we are and have been with adults. Interesting, that's very much the professional space. When you go into the community space, and we call it localities in West Suffolk, it's connecting in Ipswich and East. I'm not sure what the North Essex term is. Guess what? The community don't care about any of this, and all the charities, they're saying, look, I'm coming here with my family's head on it. Children and adults are interwoven together, so please respond differently. So I think we've got that tension in our system, but it's helpful to set out our strategy should be to have ints, professional ints, working for families and for adults. But there's a sort of practicality to making it happen that it means that we often break it up into deliverable chunks.
Thank you, Peter. It was a great response. And I if some of that breaking up within the system as opposed to out in the community comes from a sense of the specialness that children's issues are different and there are different regulations and all the rest of it and different partners. And some of that comes out of the children's sector. I like challenging. It's been wonderful for the last year to have responsibility for both children and adult, because one sees much more clearly the golden thread. And you can always schedule me on that in another day, Suzanne. But the understanding how the golden thread to optimize quality of life, and if you go back to the last paper, of reducing the inequalities of healthy life expectancy, which are even more stark than the inequalities of life expectancy.
So Will's got his hand up, but then we need to let Vimy continue.
But I know that I'm enjoying this. Right, so Will, I'll take you, and then Billy, I promise I'll come back to you.
Yeah, thanks, John. And I realise you're beyond the time pressure, and it might be that we're going to get the answer to this in the rest of the presentation, but just following up on that really helpful discussion, transitioning between childhood and adults, that transitioning sort of 18, 19 years of age issue presents so many challenges at times. So if we're going to cover that, that's fine, but perhaps some thoughts on the transition risks and issues will be helpful. Thank you, John.
Thank you, Bill. All right, Billy.
Hi, shall I come back in?
Yes, Vimy, yeah, I do.
So no, I just to, if that's okay, just to go off script a moment. Clement and Louise, we were saying we have our int-wide summits where we get about 100 people in the room, and at the last meeting, as Clement explained, we had NHS Federation there, and I see it as a long friendship. So the longer we're into these partnerships and friendships or marriages, the more of these sort of clunky challenges we get about developing further. And some of the things you've just raised in response to Clement's bit of the presentation are exactly the clunky bits that we are looking at. So I just wanted to sort of say that, but I'll carry on. Sorry. So I'm not actually from an inn. I've been here for a relatively short period of time, and the work the development team are doing are building on the 10 years of work of bringing care closer to home that people in this room have led on. And we do work across Suffolk, but very closely with Essex. So we work with the 16 ints across Suffolk that covers about 800 professionals. And on what I just wanted to highlight was we were initially brought together to look at the challenge of and the impact on professionals within INTS on recording on 2 systems, as it creates delays in providing the right care and support. It challenges us with issues that are not being shared. It has duplication challenges, increased cost to INTS, and therefore impact on the people we work with in the community. What I'll do in the next few minutes is quickly describe and update this group on the priorities the INT development team have been focusing on over the last few months. And all this activity has been done in co-production. So the first area I wanted to talk about was a piece of feedback we had was that there was no collective vision across Suffolk. And I know that a vision might feel a bit abstract to people, but in developing this vision, it's really had impact as it's opened doors and conversations around governance, data, and national engagement. And it's really helped us overcome barriers, including some funding, governance, around data sharing and professional autonomy. We've shared in the slide pack the co-produced vision, and it's really helped us shift our conversation and help us be clear that we need to engage with CYP, the voluntary sector, mental health, learning disabilities, and PCN colleagues, and we all need to be at the table. We've also done a big piece of work around integration and recording. So we spoke about this earlier, didn't we? So professionals have told us clearly through our co-production work that there's lack of integration between the recording systems, and this risks safety. We have worked really closely with the shared care record team, and they have been, really valuable in providing that ongoing training. However, in addition to this, we've had 30 meetings with over 80 professionals, and we've co-produced a core spine of common fields that all practitioners within neighbourhood working should be able to see. And in the information pack, we've listed those, but some of them include flags and urgent and alerts, basic personal details, and outcomes of a person's plan. We're now working with system colleagues and information governance colleagues to make sure that we can make those changes. And I just wanted to highlight, actually, that 6 months ago, we were really concerned about why these things might not be possible to do. And we were concerned that things like information governance, capacity, time, resource would be barriers. However, it's those people now we've got our vision and these functions that become really supportive in making sure we can have this progress made. Also really pleased that beyond this short-term work, we are looking at longer-term capability and working really, really closely with alongside the ICB vision about ensuring there's full interoperability by 2035. So I just wanted to say huge thanks to the digital team at SNE for enabling discussions and a workshop which allowed us to speak to technical experts about the constraints we're facing, and it outlined how systems need to help support professionals and not the other way round. I just quickly wanted to touch on integrated IT. It's not a luxury. It's fundamental. It's as important as the training, the buildings and the cultures that the integrated teams work in. And we are really working with our IT colleagues to support that integrated IT offer for professionals, and that work will continue. A really exciting piece of work is around our operational integration. So we've been building on some of the work that the West Alliance led on around learning from OT integration and occupational therapy integration and good practice that already exists. And we're now launching with 3 of the INTs in the East to pilot a single triage and allocation model that will ensure greater collaboration between health and social care occupational therapists, and this will strengthen the community model. This includes skills mixing, smarter processes, and this proof of concept approach will share learning. So we're really fortunate to have that professional input and time into this, and we will share that learning across the system. And then the fifth area that we've been focusing on has been communications. So the INTs asked for better communications across all their teams. And we now have the county-wide newsletter, which features case studies, training and updates. I know it's small, but it really matters, as do the summits that Clement mentioned, and we'll keep building this. And then this month, we launched 2 bits of work that was based on feedback in terms of trying to develop that one team culture across the INTs. The first was the Suffolk Integrated Neighbourhood Portal. So those people working within the INTs have access to a portal which hosts news, contacts, case studies, training materials, and it's there to promote cross-INT working. And then we launched the Neighbourhood Knowledge Sprints this week, actually, where we will run monthly 30-minute training sessions on topics such as benefits, IT, citizens' advice. And we're really pleased, for example, that we've got Suffolk Mines coming in the new year. John, I see you're on the call. And professionals within the INTs asked for this joint training. So this is our first step towards that. And these things are in response to feedback we've had from INTs for more connection, more training. So I just quickly want to finish on why this work does matter. Obviously, it's because professionals have said it has, and they want to be enabled to be supported to support people in the community. As I mentioned, we spoke to 80 professionals across 30 meetings, and what we've put in the appendices is some of the results of those discussions. But I want to bring it back to a story about an 81-year-old man who over 90 days had 3 hospital admissions, 3 rounds of reablement, and had some palliative care. His family counted 205 professionals involved in his care, resulting in countless repetitions of the same questions around basic demographic details, around his DNR, around date of birth, toileting habits, smoke alarms, and so on. Every morning for 2 weeks, 3 different district nurses visited, and they were all frustrated they couldn't complete all 3 tasks for the gentleman. The family found themselves mediating between services just to return a hospital bed. We know from the man he didn't want to be more of a burden, and he didn't want to become less of a person. In the middle of all this, there was one professional who asked him, "What is important to you?" And that single question described as feeling like a moment of humanity, and it changed the course of his recovery. It helped restore his dignity and reclaim himself. It repositioned the relationship between him and professionals as a partnership and not one of dependency. We know from our co-production with professionals that you want to support being able to have these conversations. And don't forget, these 205 repetitions occurred over 90 days, and we know that a year on they continue. Just imagine the ongoing cost, frustration, and the risk that persist for people and professionals. So that one story sparked a piece of work that we did with Let's Talk SNE. We engaged with 70 people in our communities, and the results were sobering. Only 7% told their story once. 21% felt professionals had access to the right information, and only 31% felt their information was recorded accurately. In the pack, we've added some of the 140 comments that we received back. They included that people felt that everything about themselves should be shared. In fact, people thought it already was. There was an example of someone who was paralysed 8 years ago, yet that wasn't recorded across all professionals. Questions around what about people who have no one to advocate for them? People frustrated that they are asked to continue to repeat their story. What about people, someone said, who have to navigate cross-county boundaries, so our boundaries that we put into place? There was one example of where it led to panic attacks, having to repeat their story multiple times. And then someone told us about their benefits being stopped temporarily because their information had not been recorded. So I just wanted to say they're not just comments, these 140 comments. They're real reminders of why this work really matters and why we've been asked by Susanna to come and update, and why we're trying to continue this work with urgency. I'm now going to hand over to Louise.
Well, thank you very much, and some very powerful instances. I just need to ask Louise, can we be quite brief, because there's going to be no time for discussion. We've been talking quite a lot here. Valuable listeners.
Hi everyone, my name's Louise Caesar. I'm the Area Director for Ipswich and East Suffolk in adult social care. Thanks for having us here. I just wanted to I won't labour on this slide too much. It's quite self-explanatory why what the risk is of not doing this work. Some of the issues have been that we work in silos, we lack maximum impact, we do not align with our national directives. We're very crisis-led if we're not working in this way. It increases our costs, decreases people's independence, and our efficiency is lessened. We don't listen to the individuals that have told us that they only want to tell their story once. So we really need to see the benefits of working this way. It's quite self-explanatory. I'll keep going on to the next slide. So we're really proud of the work that we've done in our integrated space. We're advanced in the way that we deliver our services. That's not to say that we aren't on a continual journey, and we've got work ahead of us to continue to develop. And I know you touched on the CYP element of integrating with children's services. There's lots of opportunities to extend this offer, but we are proud with the work we've been doing, and we've had the feedback. Just these quotes on the screen cover the feedback that we've had about the advanced nature of our work. So what's next? What we're doing moving forward? We want to continue building our relationships across mental health, learning disabilities, housing, so many other partners, and we've got some really good relationships that we only need to enhance on. Vimy mentioned we have summits that are well represented in the system, and we continue to work to deliver them. We've got our new integrated neighbourhood portal, which is supporting our professionals to work and learn together, training and development opportunities. The interoperable health and IT system, health and care system is crucial at taking the next step of integration, and the operational integration, reducing the recording burden on professionals and people. And also, Vimy touched on our OT integrated approach across Ipswich and East Suffolk at the moment, where we're joining our therapists across ESNEFT and adult social care to see how we can work as one therapy service and reduce duplication. So we're testing and learning all the time to continue our integrated journey. And we continue to evaluate and our impact of that. So the question for the group really, and we'll draw this to a close so we can open for discussion, is we are continuing to build our integrated relationships across our system. For example, primary care, mental health, and really focus on this interoperable system. We need your support to realise that we want to make that one team in ethos real. We're asking the ICP to discuss now how you can support us in this journey to continue our development. Thank you.
Yeah, thank you, Louise, and you're quite right to be proud of all the work that's going on. One may thirst for more always, but it's all very important. And you will observe how there's a common theme of all these big three elements. Now, sadly, we have very little time for discussion, Louise, which is a shame. So can I take hands, please, points to make, and please keep the points really concisely if I can. But I'd like to hear from as many people on the call as possible.
So Judy Newman and Nicola Cottington.
So Judy, then Nicola, and I'll keep Suzanne watching out for more. Judy?
Yes, thank you very much. And I know lots of us are trying really hard to do a transformation piece with our INTs to make sure that integration becomes a reality. And I just wanted to mention about the EPACs. As you know, that there's been over a decade of really trying to lobby for that EPAC system, and there is now funding for Suffolk to have the My Care Choices that's been rolled out in North East Essex. That's going to be a massive step forward with some of these. Ruth Busheray is not on the call, but I know when we heard that presentation similarly at the Alliance Committee, she did just remind us that there are sometimes, if you're the second doctor on call overnight, there are times when you do have to ask people to repeat their story because there's a clinical need. So Ruth, I've just got Ruth's voice in my ear, and I'm saying that on her behalf because I think she'd say it if she was here. But point taken, and we really want the EPACs to have a major contribution towards that, Vimy. But thank you very much.
Thank you, Judy. Nicola?
Thank you. So continuing that theme, really, we've had patient stories at our trust board around not repeating, and actually sometimes that's the way that clinicians have to get an up-to-date history. So it's about having an honest conversation about why we're doing things. But I think what was really striking about that presentation was how it feels for a person experiencing the services that we provide. And I know I wasn't here for the point on the sustainability review, but I think what's really helpful to kind of link all of these pieces is to see productivity and reduction of waste from a person's point of view, not from a services point of view. Because if we genuinely value people's time, then we will see that kind of productivity gain as a very positive thing, because duplication and repetition is most importantly really difficult for the person experiencing those services. Yes, it causes a problem for us organisationally, but it's really a win-win. So sometimes productivity and waste reduction can be seen as quite a negative thing. It's about cuts, etc. It's not. It's about making sure that we don't waste people's time who are experiencing our services.
Good, Nicola. Susanna?
So I just wanted to come in and say that, I've been so impressed with this work for two reasons. One is that it's perfect alignment, obviously, with Future Shift and everything that we need to do. But those who know me well will know that I'm big into kind of relationships and culture. And I think the focus on the one team approach and building the teams in that way. And, the last summit event that you had, the way that the conversation landed on the issues about relationships and how that can sort of supercharge the system and help kind of grease the wheels and make the system work better for people. I thought it was really refreshing. So I think there's lots we can learn from this in lots of different ways in terms of kind of, ways that we can help kind of engineer our system, but maybe with a different head on us rather than the kind of more structural ways we've done in the past.
No, but absolutely great. And that's exactly where I was in our side conversation tonight. It's relationships for me, where it becomes the culture that we all just talk into each other. And very much, Nicola, your point from the resident's point of view. Interesting word, resident. It always implies adult, residents of all ages. Have I got any more hands?
No more hands.
I'd really love to have had a much longer discussion on that, but thank you very much to the three of you, Clement, Billy and Louise, for the presentation. We did say a 5-minute break. From Will's experience earlier, 5 minutes did not give him time to boil his kettle and get his coffee and come back, so we'll give you 7 minutes, okay? We'll come back in 7. Thanks, bye. And that was...
I'm just coming back on now. Okay.
So it's first, it's Kirsten. Well, welcome back, everybody. I hope you're feeling refreshed. And Susanna says you're all frightened of me, which is why you're so quiet. And I hope not. I really hope in the next, the last 50 minutes of this meeting, we can really get some good discussion coming, because I love it when lots of hands go up. And who better to inspire that than Kirsten? With your update from the voluntary sector, and I know that you took this to the chairs group earlier this week, had great impact, Kirsten. So good morning and welcome again.
Thank you very much, John. I'll try to be as provocative as possible so that we get a lot of discussion afterwards. Great. So thank you for letting me come back to talk about the range of external pressures that are facing the voluntary sector at the moment. You'll remember that Hannah Reid from Community Action Suffolk spoke about this at our last meeting. For those of you who were at the last ICP, trailing the State of Sector report that was just about to come out, imminently due, and has now been published. And you've got a copy of the infographic on the papers that were circulated, together with a link to an Essex Community Foundation paper entitled The Budget Impact Analysis Report. So those two documents, I think, really sum up where we are and what the impacts are on the sector at the moment. And I'll spend a few minutes only going through those and picking out some of the things that I think are the most salient points. But what I really want to do is get into the conversation about why this matters. I mean, hopefully most of us know why this matters, but we'll really explore that. And to help us do that, I've got two case studies that I want to read through. I've had to cut them down because I actually found them quite emotional myself, but I've cut them down to the basic facts. We'll look at those, and then hopefully that will provoke a really good discussion afterwards and some conversation about what we should do about it. So anyway, to get back to those two reports, I think what we can see overarching in the budget impact analysis report is there is insufficient funding in the voluntary sector to be able to perform the tasks that it needs to do. We're starting off with modest budgets anyway, and there are a lot of budget constraints impacting growth and future planning for the sector. So that is obviously a difficulty. And the funding restrictions that we're seeing are relating to all sorts of things, including employee national insurance contribution increases, but also the reduction or lack of funding available in grant funding nationally, but also locally. So this is also impacting salaries and the ability to retain or recruit talent into the sector, which obviously has an impact on the sector. And all of this is affecting resilience of the sector. There is a real need for flexible funding. And what we mean by that is funding that can be used where it is needed, particularly in supporting reserves of organisations. We're seeing a lot of organisations use up their reserves. That puts them in a massively precarious predicament if anything unexpected is going to happen. So insufficient funding is a really key part of what we're seeing in both these reports. But added to that, we're seeing increased demand, and it's not just an increase in the demand, it's an increase in the complexity of need of people coming to the charity sector. And the two case studies I'm going to read through will really demonstrate that, I think. And there's also the challenges of actually getting the support. We've got challenges in recruiting volunteers, and we've seen that since COVID, since the pandemic, and we haven't seen an increase again. People wanting to volunteer drop down, and it's still like that. Not really sure why that is, but people just making different life choices, I guess. And the first time, I think, in the State of the Sector report, we are seeing burnout as one of the top 5 challenges for organisations, burnout of staff. That's featuring in the top 5 challenges. That's a really worrying factor. And I'm not saying there wasn't burnout before, but now it's so significant that it's hit the top 5 challenges for the sector. So this is our situation. It's very difficult. And it's something that I think we need to address because I think it really matters. And let's quickly look at why it matters. I mean, there's a lot of reasons why it matters. The voluntary sector is integral to the health and care system, and I think some of the presentations we've had today have already amply demonstrated that. But that's because they can be the first port of call for people, and they can also be the last defence for people. So they are there in the system, in communities, helping people who need them. They're also a large employer locally. In the State of the Sector report, you see huge numbers, 35,000 employees, which is massive. And that means, you know, people are getting their salaries, they're sort of being able to live and be financially independent through working in the voluntary sector. But not only that, some of the people who work in the voluntary sector are people who were previously service users themselves. So we're talking about people who may have suffered health inequalities, and they're getting the support both by working in the voluntary sector, but also probably at times accepting support from the voluntary sector as well. And just as a slight digression, you'll know it's Carers Week this week. And in my organisation, I know that at least 50% of the people who work there are either carers or have recently been carers and really understand what it's like to be a carer. The theme of the week is caring for equality. And so it's really pertinent to this conversation. But I will stop digressing and get back to my point. It's really important to support the voluntary sector because they are supporting our population. And they're not just supporting them in the ways that perhaps we think about on a day-to-day basis. So I think we all know that the voluntary sector is out there in communities. There are lots of great community groups. And these are really important for supporting the population. They help with reducing loneliness and social isolation. They help with connecting people into local community events and community resources. And they also help with making sure that people meet new people and develop their own peer support networks. And all that is brilliant. But what I really want to focus on today is the complexity of the demand that we're now seeing. So I've basically got two case studies. I'm going to ping up something to read them from just to keep me concise and not going on about it. So I won't be able to see any hands up or anybody trying to make me stop, but I'll be as quick as possible with this and then we'll get on to our conversation together. So the first case study is from a Suffolk organisation called Survivors in Transition, who I'm sure you're aware of. They support people who were victims of childhood sexual abuse. And both case studies obviously are anonymised, so the names used are fictional. And I'll talk to you about a woman called Lisa, who's in her early 20s, who has survived prolonged sexual abuse and trauma throughout childhood and into adulthood. And over the past 5 years, she's cycled in and out of acute mental health settings and inpatient units following multiple suicide attempts and periods of acute crisis. Each time she's discharged from hospital, she returns to the community with little or no trauma-informed support, where she lives in supported accommodation, often landing back in A&E within days. She has engaged with statutory services repeatedly, but the root causes of her trauma and lack of sustained specialist care remain unaddressed. Lisa was referred to Survivors in Transition during a crisis point, but due to the overwhelming demand and the charity's limited funding, restricted by short-term grants and rigid commissioning, they have only been able to offer her a holding service. And what that basically means is she gets basic check-ins, brief emotional support and signposting, and that's rather than the long-term trauma specialist therapy and advocacy that she so desperately needs and they usually would be able to provide. So she struggles to stay engaged and to engage. The Survivors in Transition team have also spent more than 60 hours over the last 3 months tracking down professionals who should be coordinating Lisa's care. So the Survivors in Transition team, they can see what Lisa needs. They know how to help her and stabilise her and help her begin to heal, but their hands are tied by the constraints of the charity sector under immense strain. They've got rising referrals, exhausted staff, and funding pots that favour new projects over core services, as well as poor referral pathways between the voluntary sector and statutory services, and a real inability sometimes to offer a team around the person approach. Lisa's not unique. She's one of many individuals Without urgent investment in trauma specialist long-term support, women like her will continue to fall through the cracks, caught in a cycle of crisis, discharge and despair. So I have to say both of these are quite hard-hitting case studies. I'll go on to the second one just so we crack on with time. This one is from an organisation in North East Essex called RAMA, which is Refugee Asylum Seeker Migrant Action. And part of RAMA's work is to support equity of access for their clients in regards to health and mental health services. Most of RAMA's clients have no previous history of poor mental health, and any challenges they do face are probably the result of fleeing war or conflict, or even the experience of going through our own immigration system. There is a genuine fear among their clients that owning up to any health or mental health issue is a reflection of weakness and could negatively impact their chances of remaining in the UK. There are other barriers, of course, to accessing support as well, and that can be lack of translation and interpreting services, and also a lack of understanding of our health and care system, which is completely unsurprising. So in this particular case, on the 24th of May this year, one of their clients, a Sudanese man, killed himself at the train station in Colchester. We're going to refer to him as Ali. He was 32 years old. He and his brother had fled Sudan a few years ago, and they'd been en route kidnapped and separated by people traffickers. And they had experienced, both of them, slavery, exploitation, torture, forced labour, and Ali had also been forced into sexual exploitation. So Ali's brother had been a client of Rama for a few years, about 3 years, and when he gained his immigration status as a refugee, the first thing he did was to bring Ali from Birmingham, where he'd been placed, down to Colchester. Ali also had his immigration status. Ali had very poor mental health and had been receiving monthly antipsychotic medication under the psychiatric team in Birmingham. There was no automatic transfer of care between the teams, but fortunately Ali came to Rama with his brother, who had realised that he would need some support. Rama made sure he was registered with a GP, got him an HC2 certificate for free prescriptions, helped with benefits and with working with the DWP, and found him a room in a shared house to live in. Rama's caseworker wrote several times to the GP to push a referral to the psychiatric services and explained the need for a new depot injection to be set up because Ali had missed 2 depots by that time. Support from the local mental health team was never hugely helpful. Often people would try and get in touch with Ali and there would be no interpreter when they contacted him, which meant he missed appointments and ultimately the support fizzled out. Rama signed Ali up for a new initiative starting a few weeks ago with the Haven Project, where 10 clients who spoke Arabic were going to receive 10 weeks of psychoeducation, and there would be an interpreter present at all times to help. But 3 days before he was due to start, Ali went to Colchester train station and jumped in front of a train and was killed instantly. Staff at Rama are supporting Ali's brother and other clients in the aftermath, but they still question themselves, could they have done more? Their clients too, especially those who shared a house with Ali, are finding it hard to cope now, and Rama are trying really hard to find them alternative places to stay. So Rama is not the only amazing organisation in North East Essex. You've got the Haven, Mind, Summit Services, Beacon House, Emmaus, all sorts of organisations. They all support marginalised clients, and every one of them struggles for funding. Every one of them is struggling with capacity as well at the moment, and we know that statutory systems are also struggling with capacity with long waiting lists. So those are 2 not particularly cheerful case studies to share with you, but the point of that was to show the level of need out there and the complexity of need, and the fact that in this situation that we're in, there are a lot of people who are going to be very badly let down and struggle if the voluntary sector is not supported. Now, my question to everybody is, what can we do about this? And I have 2 very early suggestions. They're not brilliant. They're not going to solve the problem. But the first one that we can all do today is sign up to the Resilience Charter and make sure we're supporting the voluntary sector in a way that the voluntary sector would feel was helpful. But the second one is, through all this change that we're all going through, and all your organisations are going through massive change, let us not drop the voluntary sector and the need to support it off our agendas. Let's keep it as high as possible. Those are my two suggestions and recommendations to take forward, but I'd be really pleased to hear other people's thoughts on this. So back to you, Chair.
Kirsten, thank you. And you did the provocative, but I very much regret to say, when you were telling the Lisa case study, I was thinking of another case study in Essex, which very similar situation, which has already led to suicide, actually, or to someone taking their own life. There is much I could say, Kirsten. Thank you very much. But let me come to Sharon Alexander.
Thank you, John. Thank you, Karen. Really tragic circumstances and case stories there. And so I quickly wrote down something that could make people feel better by citing my visit to Lads Needs Dad's 10th anniversary last Friday. It's an amazing organisation that has impacted on hundreds of young men who don't have a father figure. And because of the mentorship and support those young men have received, they stood up themselves and told the audience, which included the Lord Lieutenant of Essex, who thinks the organisation is amazing too, that if it wasn't for Lads Needs Dads, they would have gone down a path of crime, be vulnerable to drug and alcohol, had probably been one of the NHS patients, huge costs on the prison service, police, adult social care, and said because of the support that they received, they had found employment, they'd gained education. It was very uplifting, and it just goes to show what can be achieved in the voluntary sector. The points that Karen has raised, it's absolutely true. The voluntary sector is facing scenarios where we have to raid our reserves. Key personnel are leaving. I know a very close chief exec of a very vital service, extremely vital. If it wasn't for that service, so many more people would become ill and die because of the statistics. So I can't go any further, otherwise you'll know which CEO it is. She has not had a holiday in 5 years. So what can be done? It's about a change in culture and behaviour, to use Susanna's words, in grant giving and procurement. And my biggest concern, John, is what's going to happen to the VCS in North East Essex in view of the local government reform and the fact that we're not being able to consult on the reorganisation of ICBs, and then it's probably going to be one ICB for Essex, given that the ICBs in Mid and South Essex are not engaging with the voluntary sector at the level that's happening in Suffolk and North East Essex. I'm sorry if I sound emotional, but I'm going to blame Karen and the case stories. Thank you.
Sharon, on that last point, why don't you send me an email separately and I'll send you back a response, okay? But let us be very clear, the Greater Essex ICB is not to be an extension of the Mid and South ICB. It is a new ICB, and I hold you, Will and Ed, I hold Paul and Jane in Hearts and West, and the team in Mid and South themselves to make sure that happens. But I'll come back to you at greater length on that, Shannon, if you want. I've got John Neal next.
Yeah, and just wanted to firstly say thank you, Kirsten, for an excellent presentation. Quite hard hitting, but that's what we would expect. One of the ways that, so it's interesting, Sharon just brought up local government reorganisation, NHS reorganisation, because when colleagues are maybe thinking about, okay, what can we do? There's no extra money, or there's no money that can be diverted from one place to another, or it's difficult, or whatever. Sometimes it's not just about the money. And something that's happening at the moment, we've been talking in Suffolk about transforming our crisis avoidance services and maybe merging some of them together. So Suffolk Night Owls, being parochial for a minute, has been renewed until the end of the financial year. Before you know it, the end of the financial year will be on the horizon. And it's already been renewed once when it wasn't going to be. So is it going to be renewed again when it wasn't going to be? Because commissioners are understandably distracted by the NHS reorganisation, worried about whether they've got a job in the future or not, and maybe won't have any of that clarity until October, November at the earliest, by which time it's going to be too late to transform anything ready to start in the next financial year. So I suppose my reflection on what Kirsten's just shared is that that's about existing services using existing money that's with the voluntary sector already. So it's not about transforming anything away from anywhere. But there was a plan to bring us together to look at how we might do things differently to be even more effective than we already are, and to provide even better return on investment than we already do, and to provide an even better service for people that need us than we already do. But I haven't heard anything for a while about it, and it's probably been parked for the moment, and again, understandably. But that's the kind of impact that some of the stuff that's going on in the background can be having on a voluntary sector, and doesn't really give us any certainty to be able to plan further into the future. And that's one that's not about more money.
I'd like to keep this going on for the whole of time to 12 o'clock, but we've got another important topic in about 5 minutes, sadly. I've got Maria, then Rory, then Hannah. I don't want to ask you to be too brief, but if you can get to the point to let others in.
Thank you very much. Maria from Rama. Thanks very much to Kirsten for using that case study. I just want to say that one of the things that's been said to us repeatedly is, aren't we lucky that that's the first, it's a very weird term, successful suicide that we've had amongst our clients, considering that we have 5,000 clients and they come from 136 countries, which are all facing conflict. And I understand what people mean, and I know that they don't mean it in a bad way. But I also can see the fact that we are lucky because we pack a lot of care around our clients, and we are able to provide what I see as some resilience in them. So they have a place to go. They have a sense of community. They often form smaller community sub-communities. So we have a big Sudanese group in Colchester and across North East Essex who do support each other and who have wrapped their love and care around the bereaved brother of the person who died, and are doing a fantastic job. But some of our clients are not recognised. There are areas across Essex where people don't even know where dispersal clients live. They don't know where the asylum seekers are in their areas. They don't care. And unless there are services like ours who are able to provide that sense of community and build resilience in these communities, then I really do worry about the future of those people. And we all heard today about unmet needs, about the need for radical change, removing barriers, prevention. And unless we put serious money into preventing things like this, then I despair of what will happen to this area, because it's so important to support people before they reach crisis. And that's where we see ourselves. Yeah, thank you.
I'm trying to get as many people in as I can, Maria. Rory?
Thank you, Chair. Thank you, Kirsten, and thank you for sharing those case studies with us. I think, for me, fully supportive of the work that the community voluntary sector do in North East Essex Health and Wellbeing Alliance. I think the local identity, power and strengths of communities kind of their agency, insights, capabilities, capacities is so important, and the community voluntary sector are there in and alongside our people in our places, far closer than us as kind of bigger agencies than institutions. And I think that's really key. I think for me, there's something about the development of our staff and us as leaders, actually, because I don't think the tools perhaps and the skills that have traditionally worked in the past, question mark if they've worked, will stand us in good stead going forward. So I think there's something about us to reflect about how we give ourselves as leaders the skills, tools and capacities to be courageous and think differently about what we might need to do going forward to support our communities.
Thank you, Rory. Very profound, actually. Hannah, and then Will.
Yeah, thank you. I think my provocation would be that this research was done sort of December, January time. That was before ICB reorganisation was announced, before local government reorganisation, before the impact of the national insurance contributions. All of this stuff was happening then. There were services being terminated, suspended then. You know, we are looking at a year that is going to make that situation even worse. And actually, we have the resilience charter. We have these conversations constantly. Financial challenge for our sector is not new. So what are those blockers? And I agree with Rory. I think there is something around behavioural change. We know people are ultimately making those decisions. What are the blockers? What are the kind of rules of engagement that are stopping certain things happening around long-term future funding, looking at what's coming up in the time to come and what's coming to an end? What's happening with, you know, contracts that are being terminated at the very last minute, which don't allow future planning? It's those sorts of things, that kind of real action, that will change the dial on some of this, I think.
Thank you, Hannah. Yes, quite. Will?
Yeah, thank you, John. Just a suggestion for you to consider, and Susanna also, please. This is such an important subject, and the debate's been really powerful, but we don't have time to do it justice today. But it is so important, we mustn't ignore it. And the point that Hannah made about the timeline is absolutely right. You know, this was happening before reorganisation and distraction of people and so on, and we must make sure that we don't let that happen, or that we minimise its impact. I'm just wondering, Susanna, could we do an uncomfortable truths event on this specific subject, which might not only, I mean, Kirsten obviously highlighted the issues very eloquently, and but we need to get more people around the table and maintain the focus and come up with some answers and agreed solutions. I'm just, do you think that might be worth considering?
So, Will, you and I, minds were both moving in the same direction. We need a different forum. I'd much prefer to have people face to face more if we could. I think we need to allow ourselves time, but also have clarity as to what the desired outcome is, because otherwise we could go all over the place and everything. And I was going to suggest, Will, that you and I and Stephen, or if he's away, his representative from Suffolk, and Susanna, get together and have a chat about how quickly we might convene a quality time on this, whether it's uncomfortable truths. I'm not fussed about titles. I'm fussed about clarity of purpose and making sure people are going to leave this call, I suspect, having voiced their frustrations, but with no greater clue as to what the answers are.
Yeah, Andy Coops, his hand up.
Taking time away from the care sector, and I've got things to say. And come on, Andy.
Thank you, Chair. Thank you, Susanna. Very quickly, really, I completely get the call for having an independent forum to have this conversation, an in-depth conversation. Absolutely get that. But I think more critical is to have the voluntary community, faith and social enterprise sector involved in both the NHS and local government transition processes. If we can do that, you can actually make the change happen early on. So whatever you set and whatever we have in place after the transitions will be more fit for purpose.
Exactly what you say, and they're the challenge, that there are so many different dimensions of this. I'm not exactly feeling very involved in some of it myself, but there we go. Can you, if you can, let us have a think about how you see, and I get frustrated because I'd want this to be a Suffolk and Essex conversation, but that's just the way I am, really. I can't. The issues of Rama are as relevant across Essex. In fact, possibly more relevant across some parts of Essex and Suffolk. So there's the piece. We can have a conversation next week, please.
Absolutely.
Okay. Could I just say to you, and I really do have an awful lot of experience in the voluntary sector. Right at the start of this, how do we somehow recruit people back to be the volunteer forces that they were in previous generations? And it's a huge topic. And I still look at my generation as a great volunteering generation. All of my children volunteer. Is that because of parental influence? I don't know. But we've somehow got to regenerate volunteering. And I do think anchor institutions have a role on that. And secondly, if I may just come back on your point, Kirsten, could I make a plea? Don't run your reserves down. The Charity Commission give very clear guidelines as to what reserves voluntary organisations should have. And I would say to you, don't go below that without very good cause, because one of the hardest business cases to make for me or anybody else is to get organisations to give grants for the rebuilding of reserves. When organisations give grants, they want to see action as a result. And I would just, that's just based on my experience. So you have a very good ground not to reduce your reserves below a level. So do your best to keep it at that. That's a personal point. Thank you very much for really stimulating, if I know, frustrating debate, because it produced no answers. We come to the no happier topic, but it's all about today, all about the pressures everywhere, the care sector, and who's going first?
It's Matt King.
Hi, Matt. Good morning to you. And I know you're talking again on issues which are Suffolk and Essex and national. So let's focus on that. But could I really ask you, and given the time, Matt, to come to your key points?
Indeed. Thank you, Chair, and thank you for the opportunity to update on the challenges facing social care at the moment. So I'm Matt King. I'm a director at Suffolk Care Association, also the CFO at Healthcare Homes, chartered accountant by trade, and got 15 years of experience in the sector. I know I'm here to update on the challenges caused by the autumn statement, but I thought I'd just give a brief history and provide some context, discuss the fair cost of care and where that's escalated to, talk about the autumn statement, some of the other challenges facing the sector, and go on from there of how we're mitigating it. So no surprise, obviously the last 5 years for social care have been incredibly difficult, started by COVID-19 in 2020, and coming off the back of that, a number of crises. So the staffing crisis, significant increase in reliance on agency workers, and obviously encouraged to recruit from abroad to plug that gap. We were then hit by the utility crisis, which obviously saw a spike in utility costs for everybody across the nation, not only us in social care. And whilst there was support offered by government, that only mitigated to a limited extent. We then got the cost of living crisis, where general inflation has gone to, and obviously pressure to pay more staff. Going back to the fair cost of care and the amount of data that was collected in 2022, which I was heavily involved in, published on the Suffolk County Council website, is the median fair cost of care for the services that are commissioned by the council. So I've highlighted, in particular, I've paid attention here to the care home sector, but it's equally relevant to home care, learning disabilities, supported housing and daycare as well. And I just want to focus in on the care home with nursing and dementia cost. So back in 22-23, the fair cost established of delivering that service was £1,478 per week. And just looking at the impact of increases in national living wage, which obviously affects the large portion of our cost base, which has been 9.7% in 23-24, 9.8% in 24-25. And then obviously 25-26, 6.7%, but also impacted by the increases in employers' national insurance. Couple that with the things that I've previously mentioned around the utility costs and inflation costs have led to cost increases in our base costs, 12.2% in 23-24, 6.3% in 24-25, and 7.4% in 25-26. So from 3 years ago, the fair cost of delivering enhanced nursing care has moved upwards by 28.1%, and today sits nearer to £1,900 per week. Meanwhile, obviously, funding challenges with the local authority and within the ICBs mean that funding from those sources hasn't kept pace. The impact of the Autumn Statement in particular, so again, going down into a real granular level, you'll know full well that the majority of workers in the social care sector are either paid out very close to the national minimum wage or the national living wage, and therefore I've just modelled here some numbers that really calculate the effect of the impact of both the national living wage increase and the employer's national insurance. And based on somebody at national living wage working 36 hours per week, the increase to that staff cost is just shy of 10.5%, or £2,420 per person. So as a rule of thumb, we generally employ around 1.25 employees per available bed. So for a 40-bedded care home, the additional cost of the above is around about £121,000 per year. I know full well that in other sectors such as home care, the average contract hours is less. So for that sector, I think it's running around about 25 hours per week. And therefore, the impact of that increase in employers' national insurance is actually greater. So running at nearer 5% for that and 11.7% in total. So some of the other challenges just facing the care sector. So some of you may or may not be aware, but welfare services offered by state regulated providers are exempt from VAT under UK law. There were a number of providers that were implementing new VAT structures through contract restructuring, which would allow partial reclaim of input VAT. There was a HMRC briefing note released on the 24th of April, where HMRC basically confirmed that that structure was deemed a form of tax avoidance. HMRC are now refusing any new group registrations despite having given pre-clearance in the first place, and they would be reviewing and investigating existing VAT groups and that arrangement. There's actually a webinar this morning held by Care Provider Alliance, which is in attendance by HMRC and DHSE, just to deliver a consistent message around that. So whilst I know Suffolk weren't advocates of that scheme, there will be a number of providers that are either taking advantage of it or planning to take advantage of it where it's no longer possible. Workforce challenges, so a common theme in this call today, but obviously specific to social care since 9th of April, English care providers wanting to recruit new workers from abroad have had to prove that they've attempted to employ what's known as a displaced worker, so somebody already in the country who needs a visa and sponsorship. But most importantly was Keir Starmer that announced significant changes to UK immigration system, primarily focused at reducing net migration. That included tightening access to visas, requirements for English language proficiency, and longer qualifying period for indefinite to leave. The one that impacts social care is there in bold, so the government will end the exemption for social care workers, meaning employers will no longer be able to recruit from abroad. Which, if you go back a few years, given the staffing crisis and having been encouraged to go and recruit from abroad, is a massive challenge for the sector. Further, Suffolk County Council care market strategy, so the current gap in the workforce has been supported by a large influx of international staff, approximately 600 to 700 of those in the county. And obviously the cost of sponsoring and employing those people is more than a domestic worker in the first place. We've also got coming down the tracks of the Employment Rights Bill, obviously significant impact for social care providers, particularly concerning pay terms and conditions of employment. So notably around the establishment of the Adult Social Care Negotiating Body, so employers, unions and other stakeholders can negotiate minimum pay and conditions for social care workers, those being binding agreements. So at the moment the discussion is that the Fair Pay Agreement will be binding on all adult social care employers, and obviously with a view to pay increases being above the national minimum wage, with potential increases for frontline staff even further than that. So obviously cost implications for the social care sector are the pay increases and improved conditions, which is going to mean increased costs for social care providers. The funding, which I know Kirsten mentioned, is insufficient currently and is challenged. So the impact of that increased pay and how it will be funded. And then some other terms around 0 hours contracts, which are heavily used in the home care sector, not for exploitative reasons, but just for practicality reasons. And then the need for offering flexible working and strengthening protections to the employees. Obviously, earlier this week we had the spending review as well, which was relatively mute on social care. But I do recognise in the background there was announced an increase in funding by £4 billion for adult social care in 28-29 though, and that's compared to 25-26 funding. But again, lacking in detail, so there's no detail of that that's been released that allows us to plan, and it's relatively small fry in relation to the sums that were awarded to the NHS. Obviously, that fund includes the increase to the NHS's minimum contribution to the Better Care Fund. And also there was discussion around the fundamental reform across social care, but again, no detail on what that looks like. Mitigating measures, so things that our providers are having to do and what they're facing at the moment. So no surprise here, higher fee increases for private fee payers. So again, talking about that fair cost of care and delta between funded state rates and private fee payers, that discrepancy is getting larger, undoubtedly. Again, to reclaw some of the impact of the employer's national insurance, which hasn't been funded. We've had to award suboptimal pay reviews for anyone earning more than national living wage. And again, that's a continuing picture of the last 3 or 4 years where differentials in pay rates for certain grades of staff have been diminishing. Cost-cutting exercises, so similar to yourselves, having to look at staffing levels, central support functions, our capital expenditure budgets, repairs and renewals to the buildings themselves and the kit that we require to run the services. And then also, obviously, on the last couple of years and been coming up the agenda is IT and digitisation, which again needs to be funded from somewhere, and the ESG initiatives to move towards net zero by 2050. Obviously, the risks that poses. So first and foremost, to the quality of care, to the residents and service users that are in receipt of our services, to the sustainability of the marketplace, and also this reduction in capacity. So again, a bit of feedback from our members here. So our care providers in Suffolk are still shell-shocked. However, they feel the pinch this month and will slim down their services, hand back care packages and placements, and make staff cuts to remain financially sustainable. In April, Suffolk Care Association organised a joint meeting of providers, local authority and ICS partners to hear how we can jointly streamline processes would save the care sector time and costs. There are several asks that have been actioned. SCA is also involved in a national lobbying of central ministers, and we know that 3 care associations in England are in the process of undertaking judicial reviews against their local authorities in regard to fee uplifts received for 25-26. That's coming back off the back of precedent set by the Stoke Association. And then Suffolk County Council and SNE have done their best to give us a fair uplift, which we're grateful for. But given their constrained budget, we're also feeling the impact on our businesses. The market remains hugely fragmented, and there are a number of small providers that will be unable to absorb some of these pressures. To date, 6 businesses have closed down since the end of February 2025, and many others are contemplating closure. Suffolk Care Association is working closely with the County Council to manage provider failure when it happens. And then just from my counterpart in Essex Care Association, Sir Simon Harney, said most of our members are SMEs and less able to absorb these costs. And we are particularly concerned about those who have a higher proportion of local authority clients where there is no scope to increase fees. We are also concerned about the impact on providers of smaller services, such as those for adults with learning disabilities, where 1 or 2 voids will have a much bigger impact on their viability than a large care home. We do not think that the full impact of the changes has yet been felt, and many providers will have absorbed the additional employer costs this time, but will increasingly struggle to do so as time goes on. We are also concerned that some providers might decide to make savings that will impact quality, and there is evidence that some commissioners will continue to buy services from providers with poor quality ratings simply because they are cheaper. This is likely to lead to worse outcomes for individuals and will impact on the wider health and social care system. ECA has lobbied local MPs and ministers on these issues, but it appears there is no flexibility and limited understanding of how the sector operates. We continue to work closely with Essex County Council and are pleased that they were able to fund better provider uplifts here than in other parts of the country.
So you're nearly finished, mate?
I am indeed, yeah. So again, thank you for your time. And obviously key for us is to work in partnership with the local authority and ICBs to help lobby central government to ensure funding of social care is fair and sustainable.
Thank you. It was exhaustive and depressing, really. Nothing new from my perspective. There'd be something very strange if there was, as I've done this role for over 8 years. But again, bringing home the totality of it. I know one or two people have asked for copies of the slides. I assume there's no reason why not, Matt.
Absolutely not. No, they can be shared.
Okay.
Will Pope?
Yeah. Well, before I bring you in, can I just see if there's anybody else first, if you don't mind? Is there anybody else? I mean, this is very much a noting piece.
Moira.
Moira, yes.
Yeah, and absolutely understand and share, significantly share your concerns, Matt. And I'm glad you were able to kind of give the feedback from Simon, the work, the conversations we're having with Essex Care Association. I think we are trying to understand the kind of impact of the spending review, and particularly kind of when some of the regulation that you touched on is going to come in, and the potential for kind of we know that all of this is kind of driving additional cost in the sector, and the ability for providers to absorb that additional cost. These are real additional costs. They're not things you can efficiently gain your way out of, particularly given some of the small organisations that you and Simon mentioned. We're just to kind of assure colleagues we're having really active conversations in Essex. We're trying to maximise the resource that we've been able to put into the sector. But to give you some idea of the scale of the gap on residential care, for example, when we calculated that last year to meet the full cost of care would be around 35 million in addition to the money that we've put in. So we're about, we know nationally we're about a third below the cost of care in residential. Varies a bit between authorities, but broadly that would be the case. And it absolutely has to be subsidised by the rates paid to private fee payers. But what we've seen this year is we're seeing significant numbers of people now dropping out of being able to pay for their own care. So then the local authorities needing to pick up those costs. So all that's happening is people are getting through the resource that they do have quicker with the rising cost.
And that's both the demand side and the complexity, Moira. Thank you. If there's nobody, we're not going to solve this today, but it is absolutely true, the point you're making. But I'll bring you in. I'm probably going to say something quite provocative after that, though. So, Will?
Yeah, mine's been done, John. I was going to ask you exactly what you said. The great paper, Matt. Thank you. And I think if we could circulate it, I'd really appreciate that.
Right. As far as you're concerned, Moira, I think we need a paper for the Essex County Council cabinet team, not just about the spending review, but about the totality of what's just been described, the impact of the announcements about foreign workers coming in, and all of these different elements, really.
John, we're meeting. So I was just going to say
we can debate that offline, okay, Matt. So here's the challenge, I think, really. So I've been around now best part of a decade. And throughout the decade, I've been told this is it. This is the point. And I think one of the challenges that the care sector has got is how do we work together with you to talk most effectively to government? We're clearly not getting there. And I'm not making any political points. It didn't happen under the previous government anyway. Incidentally, I might have felt I was quite a good candidate for the Casey Commission. I got as far as getting acknowledgement from Baroness Casey's teams that I assume that's all it's going. And they did say that we're not going to get the outcome of that review now till 2028. So there's going to be no reforms in the lifetime of this government, of this parliament. The pieces, the challenge we've got is that the message is somewhat jaded because it's been said quite rightly before. And people say, well, they say that every time. And what we have to think about, and I'm stressing the word we, is how do you somehow create a different voice in this space that penetrates where the ears don't want to listen? And one can rely on the national piece going on, and we should. But I'd certainly be saying to you and to Stephen and Simon and anybody else from the two care associations, might we somehow be better finding, or no, might be sometimes be better additionally to think about how we can get the case through in that very unwelcoming ears. Okay, Matt?
Yeah, no, understood. And I completely agree with you, sir.
Oh gosh, I wouldn't go as far as sir. That's getting carried away. I might be scary, but I'm not a sir, really. Right, okay. Any other points on this? It's been a sobering morning, hasn't it, really? It's just a reminder that however brilliant SNE can be, sometimes the challenge is you can be the best sailor in the world, but sometimes the storms of the Atlantic get a bit much even for you. Anybody else?
No hands.
No, thanks, Matt. Thanks very much. And thanks to Simon. I don't know if he's on the call or not for your help. Susanna, anything else needing to be said at this point?
So I've not been advised of any other business, and I'm also not aware of any questions from the public on the live stream, which has obviously been running throughout. I've just got a couple of updates which are on the end of the agenda. So obviously, given everything going on at the moment, it is important just to keep talking. Might be more difficult to make progress on some things than we'd like, but we do need to keep talking. So 2 or 3 things from my team's point of view. The first is that at the moment we've got large numbers of staff affected by change, and this is as good a time as any to kind of have a little bit of time out to brush up on some of the kind of fundamentals of working in health and care. So my team are going to be offering, I'm going to write around to all of you as ICP committee members with the offer of a number of courses that we're running over the summer as a sort of summer school on themes around system working, managing relationships, cultural leadership, and using data and knowledge and so on. So those are free of charge. They're in community venues around SNE over the summer, and we'd really like to have a mix of people there. So we're going to make it fun for the people involved, but hopefully it's an opportunity to kind of brush up on some of those skills. The second thing is that obviously I did write to all of you to let you know that we did decide to postpone our annual expo event until kind of the way forward is a little bit clearer. But what we are still going ahead with is our ICS Awards ceremony. So again, I've written out to all of you about this. Our awards have been enormously successful this year. We had more than 200 nominations, which we've whittled down to a shortlist of around about 90 shortlisted nominees. And we're going to be announcing the final awards across 10 categories on Friday the 4th of July at Newmarket Racecourse. It's in the afternoon. We won't have room for everybody in the entire system. We can't fit in 1,500 people at the awards, but we can definitely fit in some of you as leaders if you'd like to come on and support, particularly where you've got nominees from your organisations. If you have a look at the shortlist, you'll find that there are nominees from right across the spectrum, from local government, the voluntary community sector, social care, obviously all parts of the NHS, mental health and acute, and the ambulance service as well. So that's a nice way to spend the afternoon. If you want a little bit of inspiration there, look no further. And then last but not least, we are going to go ahead with 2 things which were themes for our expo, but we want to continue with them. So one is that in the autumn, we're going to have 2 events, one around innovation and the other one is going to be around culture and leadership. So again, I will be in touch with you as committee members. If you wouldn't mind passing on the details of those to the people in your organisations most appropriate to attend, I'd be grateful. I think my bottom line message is these are important things and we need to keep talking about them. Thank you.
Oh, thank you indeed. Indeed, talking about them and finding ways to act on them. Thank you, Susanna. Can I thank you, Susanna, and all your team for your help in managing me, a hard task, and managing the agenda. Thanks to all of you for your participation. Much to think about, and I wish you a very happy weekend. I shall go off and meet my Europeans. I've got Swedes, Germans and Belgians living in the house with me this weekend. So very best wishes to you all. And if anybody is going on holiday, have a very good and well-deserved break, because I think you'll need it. Take care. Bye-bye.